to welcome Mr. Amit Anand sir, who will walk us through the basics of audiology and its clinical significance. One small request: we have 5 active listeners for this session, so request you all to be active. Thank you.
Good afternoon, everyone. And I know that after this, it is a break time. So it is going to be a very practical session, and we will question answer session is also there. So I will learn also from you. You will learn also something from me. Okay. So we will start this. So they are my audiologists. They are very qualified, and they are really having. They are also all RCI registered. And we are Asia first clinic has done EAS cochlear implant with monitoring cochlear function response in real time while inserting the electrodes. And we are doing almost all the audiological test assessments, speech assessments, language assessment, everything we do. And we are regularly doing real ear measurement, regular mapping, advanced level CI mapping with validation test. And whenever it is required, we are doing even EAVR with CI. So my life journey, I have met many prominent peoples like Baba Ramdev, Modi Sahib, Bajubhai Bada Sahib, RJ Devki, Geeta Rabari, and many prominent personalities. So I will jump to case. This is a case 1, and where the age of child is 10 years, and they noticed at the age of 8 years that they have hearing loss. And we have taken case history, and we have diagnosed that it was a bilateral mild to moderately severe SN hearing loss. So this was like an audiogram, and then in case history, what we found, child was having articulation problem, he can follow verbal commands inconsistently, and he likes more volume to TV, and he had poor scholastic performance, referred by one ENT surgeon just to check the audiometry, and we found it this. So, and we have fitted hearing aid bilaterally. So what happened when we tried case history, then his father also told I have hearing loss. Okay. So we assessed his father was 39 years old. Then we have taken again case history for his father, and we did audiogram. So what we found, history was diabetes, mother has hearing loss, his mother had hearing loss due to age, and he was having difficulties in hearing with mobile from left side only, his father, okay, son father. So we did audiogram, it was right ear normal hearing sensitivity, and left ear mild to moderate high frequency SN hearing loss. And then we have done speech scores where we found in left ear it was 40% SDS, speech discrimination scores. And impedance also we have done A-type both side, IPSI present and contra present at 5 and 1 kilohertz in right side, and IPSI present at 500 and 1 kilohertz contra present in left ear. Impedance was also not that much significant. And okay, then doctor asked to do CC and TDT. So CC and TDT both tests were negative. Okay, so what we have done, CC we used 5 dB increment, and TDT was also negative. At 5 dB CC it was negative. So what do you think that already you know the history of father, son, what should be the cause of hearing loss? If anybody can say, anybody can ask any question also further, but what do you think? There are many causes like hereditary injury, diabetes, overuse of mobile phone, acoustic trauma, mumps, Bell's palsy, Meniere's disease, etc. So what do you think? What comes in your first, that what should be the one choice? Hereditary, yes. Child, there is no medical history, nothing.
Hereditary, sir.
Nothing. No any major medical history. So one who said hereditary? Why you said hereditary?
So mother is also having a hearing loss, and father is also having due to diabetes hearing loss. So for
Okay.
that continuation, the child has also.
Then why father has only one side hearing loss? Onset of father hearing loss. Just he came, we diagnosed, and he just said that last 2 to 3 years I am struggling from this side of hearing. So can you test my hearing also? Because he came to that clinic, and that time he said that I want to check myself also. Because one side it was normal, one mild to moderate, so he was not worried about hearing loss. See, what happened, why it is a basic. See, every day what we do, we also do the basic things, okay? Sometimes we go to five-star hospital, five-star hotel. Sometimes we go to resort. Sometimes we go here and there. But every day what we are doing, regular thing. What we have done, only regular testing we have done. And their clues is there only. Clues is there. What is the big clues? Overall use of mobile phone, it should have some NIHL pattern, no noise induced pattern, but pattern was not noise induced. Because this kind of patient will come to your clinic. If doctor will say that you do CC and TDT, what you will write? You will write negative, negative. Then what doctor will do? Because he doesn't have any other symptoms, but he has given a very big cues that you have to understand the cues. How can you say acoustic neuroma? Unilateral sensory neural has lots of reason. Yes. Acoustic trauma. Vertigo, why acoustic neuroma should have vertigo? Because acoustic neuroma affects what? Vestibular organ also. So he is telling that if he has any vestibular symptoms, then it can we can predict that he has acoustic neuroma, but he doesn't have any symptoms. Which slide you want? See, I will tell you the cues is here. Here is a cues. See, at CC when we do, CC at what increment? 1 dB. What is that? 5 dB. And 5 dB it is negative. It means what? 5 dB. No, it is not a main years again, because what happened in RCP, in retrocochlear pathology, what happens? Like speech discrimination becomes low. What he guessed that speech discrimination was very low compared to audiogram. Okay. So if I am saying what is your name, but he is not able to understand what is your name, because in speech what kind of cues are there? Many cues, that is fluctuating cues, this and that, many things, but he is not understanding. It means increment was 5 dB negative. So just I asked to my ENT surgeon, I think there is some big problem because SDS is low, 5 dB increment is negative, and he is not able to understand with mobile phone. In mild to moderate, they should understand. Okay. So the case was diagnosed as acoustic neuroma. Okay. So in acoustic neuroma, you can see that this side is a normal. This is a ear, and this is a vestibular system. Okay. And this side you can see, this is the acoustic neuroma, which is affecting vestibular organ and cochlea also. Now, why this patient is not having balance problem? Anybody can say. Acoustic neuroma also can be called vestibular schwannoma. So vestibular, first is it is affecting vestibular, then it is affecting that thing. Then why he didn't get any kind of balance problem? It was fully affected.
The spread of the tumor, maybe the size that can have been.
No. See,
West-
जब चक्कर आता है, then क्या होता है? BPPV में चक्कर आया. Then what we do? Like one vestibular session is also there by Dr. Chandrakant. Okay. So after giving the medications or after some days, they become fine. But do you think that he has become fully cured? No, why? But now he is fine.
Adaptation.
Adaptation, yes, this is adaptation. It is a very slow rising tumor. So slowly vestibulars get adapted. So you will not get any kind of balance problem. You will get first hearing loss. So already this question answer is done. So see, if there are, we are doing CCTD, what is the role? If there is a one-side hearing loss and discrimination score is big, then why we should do any special test? They should go directly to the MRI, okay? So why we are doing that? Because there are many cases we cannot do MRI also. There are many situations like metallic implant, sub-implant is there. There the side you cannot do MRI due to some reason. Screw is there, claustrophobia, they don't want to go. Whatever the condition, I will not go to the MRI machine. Obesity, they are very fat, but MRI machine cannot take him in. So that could be the many reason MRI we cannot do. It doesn't mean that we cannot diagnose the acoustic neuroma. So then what doctor will tell? They will tell, okay, you do Bera. Okay? This is a normal Bera or this is a acoustic neuroma wala Bera? Anybody can say? This is a normal or abnormal? If right and left, this both waves are there. This is normal, everything is normal, okay? No, not much difference. This is normal Bera, abnormal Bera? Abnormal. So what do you think? This is cochlear pathology, retrocochlear pathology? Retrocochlear pathology. Yes, why, no, you are saying interpeak latency and here we can see latency difference between both ears, right and left. So this is a really cochlear pathology or retrocochlear? One said retrocochlear. Retro. Everybody is saying retrocochlear. If you will take this kind of graph, then you will think that this is a retrocochlear pathology. If one side hearing loss is normal, just forget about the previous patient. One side is normal and second side is mild to moderate hearing loss. And see the intensity, 60 dB. Same intensity they have done. So how it can be retrocochlear pathology? Because one side is a hearing loss, that side, that's why the latency difference was there. So, no, not conductive hearing loss. What I say, if one side is having mild to moderate hearing loss, one side is normal, and if you want to differentiate retrocochlear pathology and cochlear pathology with Bera, and you are doing only simple Bera, how you can find out that there is a retrocochlear cochlear? Then you have to do that I will come on that also. So first we have to do ABLB, okay? Because they might have recruitment also. So you have to balance. If that side is, the similarity should be there, okay? The balance, somebody is having like the same configuration. 3% is having mild to moderate, mild to moderate, mild to moderate. But the loudness might be different. So you have to choose same loudness. And if you are choosing the same loudness, and there is no peak latency difference between two ears, then it is cochlear, and if it is there, then it is retrocochlear. You can suspect. So now somebody said neurolatency. Okay. So if you want to do neurolatency Bera, then also you can do. There are many instruments. It is pre-programmed also, and you can do manually also. So in manually, what you will do? What stimulus you will take? Change the rates. What rates? Means what two rates you want to take? No. What two rates? Low rate means what? High rate means what? 11 and
90.
80, 90. Okay. Great. You can take any rates, but you should know what latency difference would be there. Okay. So see here, it is the same latency difference is there. It is 50. Then this is, and the rate it is showing here, R1 and R2 it has taken, and here also we have taken. So there is a latency difference is coming. So how we will diagnose? Like you have taken, somebody has taken 8 and 88. Somebody has taken different rates. How you will know that this is really coming under normal range or it is the abnormal range? How you will check? Anybody will say? Normatives, it is normatives. What is normatives? No, what is a normal? Yes, every one rate it is 1.1. There could be the difference, like one theory is saying that, and one other theory can be, but it will be the minor difference. Okay, so you have to check. Huh.
Only the rate of stimulus will not be sufficient to.
No, I am not
Right.
telling about. I am
Right.
telling about the base,
Right.
based on this, because this test is based for the retrocochlear pathology and cochlear
No,
pathology.
understood.
Hmm.
Sir, what I think, like we can go the LI function also.
Which
Like
function?
LI function, latency intensity function across the various intensities.
That we can do, but I am telling about only about neurolatency. How you will diagnose with the neurolatency. We have lots of things to
Strategies,
diagnose.
right.
Yeah. And if we are talking about Bera, okay, so we are talking about the preservation. Also, you have learnt about the preservation of cochlea. Okay, so what we are doing, functional or we are doing surgery? Functional test. So we say surgeon, we ask patients that you choose thinnest electrode. You go for the best implant because it will not injure your cochlea. You are injuring the cochlea. Do you think I have injured? I think in the first when I have started my practice, I might have done. And many people are doing also. Okay. So if we are thinking that company peoples are investing crores and crores rupees, patients are investing lakhs and lakhs rupees to preserve the cochlea because they want best. What we have to do? How we can preserve the cochlea? What should be taken care? What should be the bullet point? Start with the lesser intensity. If somebody has sloping hearing loss, somebody is having loss at the 60, 70 like that, and we are doing the intensity up to 90 dBHL, 95 dBHL. So what we are doing, functionally we are disabling. We are giving more hearing loss to them. So we are doing a crime. So that we need to be taken care. It should be taken care, okay? Stop when you confirm there is a peak, okay? If there is a earwax, first you have to evaluate earwax. Otherwise, what will happen if there is a earwax you have done, that patient has gone to other centers, they will check, and then parents will claim on you that why you have not checked, and unnecessarily my child has gone once more for the Bera testing. And then insert phone, it should be cleaned. Impedance audiometry should be done prior to Bera. OE, if OE is required, then you do OE first. And then see, if we are doing NHL and HL comparison, somebody is thinking, okay, I'm giving only 80 dB in the Bera, and whatever we are doing in the 80 dB in audiogram. So it is not same. Which is higher? NHL is higher. What is the correlation between NHL and HL? Anybody can say?
20 dB.
20 dB. Pakka. Actually, there is no, we cannot direct correlate because we are using different stimulus, no? Like we are doing chirp, okay? We are doing narrow band, we are doing clicks. So there are many different, roughly you can say 15, 20, 22, like every frequency, it has different domains. So that should be taken care. So like this, see what has happened when you have confirmed the hearing is there. You have confirmed even if you can take 2 peaks and hearing is there. Many doctors will say why you have not gone up. Okay, why you have taken only 2 frequency. You have to talk. You have to convince that why I am not going up. Here what it has been done till 70 dB. Why we should go up? If in audiogram, if we are doing at 40 dB, he is listening, we will check 50, 60, 70, 80, 90, 110. In same way, we have to do Vera.
Sorry to interrupt. Can we continue in 2 minutes after a break? Actually, Aparna ma'am is leaving, so we wanted to do a geotag photo with all of us on the stage here. So let's all gather for the geotag photo and we continue sir's session immediately. All of you please come and we set up for the geotag photo. ये उनके पास सिर्फ वीडियो हाँ पर का फोन
Aparna ma'am is leaving from all of us. She has a flight by 3:40. Hello, listen everyone, listen carefully. Aparna ma'am is leaving, so we are really thankful to her. She has attended this Connect workshop. Because of her presence, this event was really good. Thank you very much, ma'am, for attend this event.
Thank you, ma'am, for being with us for this workshop. Thanks once again.
There, but I'm really looking forward to ISHACON. And we have to make it really a landmark benchmark. आपने जैसे बोला था, so I'm looking forward to that.
Thank you, ma'am. Thank you.
all of you please settle down so we continue Amit sir's session. Everybody settle down.
कितना मेडल है राम प्रवेश? 5? 5 है? 5 देना है? नहीं, 5 देना। 5 एक्टिव लिसनर को देखा ही नहीं, अभी तक देखा नहीं था, अब देखना पड़ेगा। So then there is another slide. Like now we don't have to do, we cannot increase our beta intensity when you have confirmed hearing loss is either you have got the peaks. Okay, so we should not go up and up. So what is this? Anybody can guess? If anybody can guess, what test is this?
LLR.
LLR corticals. Yes, we are doing regularly corticals. Why we should do corticals? Like if we are doing beta, then we need to do corticals? Yes. Why? There is anybody can give the reason? Yes, we should see in the auditory cortex.
Cortex, yeah.
Yes. But we can tell something in very simply that why we will do LLR. Like, can you give some case examples? Like, some case has
Like
come
you
to
have
you.
auditory neuropathy, so the beta will be absent. But in
Okay.
cortical, if you are getting response, then yes, there are fibers which are responding to low repetition rate. So you must check with LLR whether there is response or not.
Yeah, if we have auditory neuropathy case and
Also,
if we are getting LLR, then
Benefit
it
with the
means.
device.
Yes.
So if you have given hearing aids or if you have given cochlear implant, you can do corticals and you can check whether the brain is receptive to those sounds or not. So in
Yes.
non-verbal.
Yes, and sometimes even we can do LLR based cochlear implant mapping also, and it is generally used in in Australia. It in a routine used. Okay, even in sometimes what happen if case has come, you have to give the optimum mapping. Okay, how you will do if they are going after 7 days, 10 days. Many patients are coming to us and they have we have done the surgery and then they are going after 7 or 10 days of switch on. So we have to give very optimum mapping. Okay, so even we can use even not in case of only a child, we can use even in case of adult also, because adult when you will switch on, they will not tell you that at what loudness they are hearing first time, so they will be shocked. Okay. So LLR has many use. So now audiologists should understand if we are uplifting our profession, we should look LLR, aided LLR. Generally we do aided LLR maximum. LLR also it depends on the need of diagnosis. If we have done beta, if we have done LLR, we have found out, yeah, this is a case of hearing aid, this is a case of cochlear implant. Anything in between? Yes, what it is called? Yes, full form? Stimulation, yes. Previously, what it was called? This kind of implant, hybrid implant. Okay. So don't get confused between hybrid and EAS. So EAS has biggest role of audiologist. Okay, we have biggest role in this. This is something called one device AIM, where you can monitor when surgeon is inserting the electrodes, then what will happen if somebody is having this kind of hearing loss, this kind. Here you can acoustically amplify, here you can electrically amplify. So in the same ear, you are giving hearing aid. In the same ear, you are giving the cochlear implant. Means you are stimulating electrically also, you are stimulating acoustically also. So how we will monitor? Because if surgeon is inserting the electrode, you have a consult. No, nothing will happen. You are a candidate of EAS, and we will stimulate your lower frequency response will be better. Don't worry about that. But you have said, and when surgeon is inserting the electrodes, it can damage the cochlea also, no? So how we will monitor it is not getting damaged? We can monitor through EMS. EMS is what? It is giving the ECOG response, electrocochleography. So how do we do electrocochlearography? Electrodes we are putting on the tympanic membrane. Here, where is the electrodes? It is going to cochlea. So we are getting response directly from the cochlea. So what will happen? They will insert. And if ECOG is present, then okay, if it is getting absent, then surgeon has to stop the inserting the electrodes. Then again he has to wait, little bit he will change the angle, again the response will come, again he will insert. Okay, so it will take 3 minutes to 12 minutes. So surgeon hand should be very steady, he should be very calm, he should be very relaxed, and OT room should be very silent. Okay, if he will be in the stress, then it will be very difficult, because the very thin part, very small part you have to insert inside the cochlea. It has, like, it can be inserted with the round window approach, and this is an intraoperative monitoring. Who will see that? Who will observe that? What is happening? Audiologist has to see, and audiologist has to check, because you have already consulted the patient, and further you have to consult the patient. Okay. So it looks like something like that. RIC hearing aid already you have seen, and cochlear implant processor you have seen. So it is a combination of both. This is a processor, outside processor. So we have done one case who was having this kind of audiogram. Okay, and after doing EAS, now it is almost 1 year, I think, and he is doing well. This child has developed 70% language. Okay, he can understand everything. But her mother said, "Sir, is really very, you misarticulated." Then in the crowded situation, in the noise situation, he was having much difficulties. And after doing this, after 1 year, he is doing tremendously well. There is no problem. So you can see the window. If you know about cochlear implant software, see, here is the electric cutoff criteria. Here you have given the acoustic cutoff criteria. So you can manage, like if somebody has progressive hearing loss. So tomorrow, if lower frequency has become down, so you can adjust the electrodes current level from this software. So this we have done for this child, and then how it is even after cochlear implant, you can do objective audiogram through ECOG. Okay, this is AIMS machine, and post-operatively you can do. How it will give you? See, it is showing the audiometry result it will show. So here you can see it is giving the thresholds. So we have done post-operatively, and we found whatever he was having hearing loss, the same hearing loss was there even after doing the surgery. Post-operatively, we had same result, not even 5 dB changes. Okay, so as in clinics, if patients are coming to you and you are fitting the hearing aid, and they are coming so many times, they are saying, "No, I am not satisfied. I am not hearing. I am not satisfied in the group setting. This hearing aid is bekar. You do something. You do the programming. Every 15 days, 20 days, they are coming to your clinic. What you will do?" You have to think about 60 dB criteria. If PTA average is 60 dB, and if less or equal to speech discrimination is 60%, then we can think about cochlear implant, or we can evaluate about cochlear implant, or we can do cochlear implant. What is the 3 choice? What we should do? If this is the criteria, then what we have to do? All 3. So first what we will do? First we will evaluate. Okay? That questionnaire, whatever is there, whatever question you have, hearing handicapped index, or whatever questionnaire, you can see, and you can see the requirement. And then you can see that this is a really, now I cannot give anything with the hearing aid optimization. Then we can think about the cochlear implant, because it will give you the more window and patient will get satisfied. At least you will tell, no, now we cannot do anything. If you want more result, we will do cochlear implant. You are ready? Then they will not come to the for follow-up. Either they will come for follow-up with cochlear implant, thinking, yeah, I should go for cochlear implant now. So in that way, all over world, cochlear implant patients are increasing, those who are falling under this criteria. Yes, speech audiometry. If we see the pediatric guidelines, that was the adult guidelines. What is the pediatric guidelines now? The 50 dB speech recognition score, if it should be less than 50 or equal to 50 dB, and threshold is more than 70 or equal to 70 dB, and limited outcomes or progress is there, and if there is a poor quality of outcomes, then you can think for cochlear implant. You should not wait for severe to profound hearing loss. So everybody knows about speech banana. What is speech string? We should think about speech string, not speech banana now. Okay? Everybody should have this graph at the clinic. Why? For children to have sufficient auditory access, they need to hear in the string beans at the top of a speech banana. And that means threshold at 20 to 25 dB throughout the frequency range. Let's remember that soft speech is about 30 to 35 dB HL. So if we are thinking about only speech banana, many times we will say, oh no, it is within speech banana. Just you wait with the hearing aid, we will upgrade. After 1 year, one more hearing aid is coming, and you are not thinking about the cochlear implant because you don't have any idea about speech strings. Okay, so when we are doing hearing aid fitting, why we should do speech testing? All three testing, why we should do? Anybody will tell? Because in hearing aid fitting, so you are fitting only audiogram. You are only audiometry threshold. Anybody can say why we should do speech audiometry? Means for counseling, for counseling of the patient, that how much benefit they will get after hearing aid. Anything else? That is again is a counseling. Means you are not doing anything in the hearing aid. Within hearing aid you cannot do. If like one person is having 60%, 60%, 60%, speech discrimination is different. So anything you will change as per patient requirement, anything you will change in the audiometry as per your SDS score. I am talking about only speech in noise test. Just I will take only speech in noise test. We can set any criteria in the hearing aid programmings. What? Direct. Whatever the score has come, you have to put that in the hearing aid programming. How you will fit? How you will do? Like we are talking about AI. AI needs data. Okay, AI needs data. So data is what? Threshold. First is audiogram. Second is what? Speech audiometry. You have done. But how you will feed data? You can feed directly. So audiometry threshold applies your client P-tone audiogram to ensure audibility. So you have checked audibility. Second, two peoples may have identical audiograms, okay? Then but completely different speech testing values, okay? Everybody has different speech testing values. One thing is great that counseling you will do, outcomes what will come that you know, slowly you will tell that you will take little time. Even you can call for auditory rehabilitation. After cochlear implant for adult, we are telling that come for 3 months, 6 months auditory rehabilitation. Anytime we have told our patient that after fitting the hearing aid, you come for auditory rehabilitation? No. But if we will do, really they will be benefited. The value of added speech in noise performance can be filled in the programming software. Now this is a tricky. How we will feel. So you are there for a much better position to make informed decision on advanced hearing aid feature and manage your client expectation. So now we'll tell, you have not told that how we will feed. It will take really 1 or 2 hours in presentation how you will feed directly speech in noise scores in the hearing aid software. So at least 20 to 30%, they will feel better what you have done in the audiometry. Only if you are only applying audiometry, doing lots of here and there in programming software. But if you will feed this, then really they will really tell you that I have benefited by 20 to 30%. But you should do really a measurement means or same time. So that in next meeting or person to person, I will tell you how to do that because it is a big thing that I have to explain everything in that. See, if you have a 78-year-old, okay, she is not benefiting with hearing aid. she is having severe to profound hearing loss, and she has limited vision. So you think that you have to go for cochlear implant now? Okay, so how will you make sure that after doing the cochlear implant, he will hear and he will listen? She might be listen only, but she cannot understand. Okay, so how will you do that? You have any test to ensure that after doing the cochlear implant, she can understand also everything? There are many cognitive tests are available. Before doing the cochlear implant for the geriatric population, you have to do the cognitive test. Then you will get the answer that they are fit for cochlear implant or not. So we have done cognitive test for this patient also, and you can see the result. I don't know. एक मिनट. So you can see at the age of 78 also you can do the cochlear implant and you can get the best result. So, so you can see the power of audiologist. If you are doing really great practice, you can do anything. I am telling to my audiologist also whenever they join, I say don't work as a technician. What they say, A type, B type, what is that? You have to think that sound is going inside, then where it is getting affected, what changes are happening, what results you are getting. So you have to think as a whole. It is not like that you have done some patient has come A type, mild to moderately severe hearing loss. It is SN hearing loss, it is mixed hearing loss. Then you will never uplift yourself. You have to think what has happened. When I have started my practice, I had lots of fight with the ENT surgeon. Okay, it was 1 month, 2 months, 3 months, and after 3, 4, 6 months, they will say, whatever you are telling, that is the final decision. Okay, many times, not in audiology, even in speech, even in voice, and even in language also, because they have different perceptions. So perception can be changed because we are true professionals. We are not technicians, not like opthal technicians. We are audiologists. We have technicians. Those who have done DHLS, they are technicians. They will not think what we think. So if you don't think differently, then you will become directly or indirectly technician only. Okay, so we should look patient as a whole. We should have a strong organization like what GISA we have. So every 3 months, every 6 months, anybody can present, because if I have presented, you have learned something. If you are discussing something, I have learned something. So this is the exchange of ideas. Okay. So we can learn and we can think, even we can discuss. If somebody has planning for LLR, so if they can come to our clinic, they can understand how you are doing LLR, what you are doing LLR, what extra we can do there. If you are doing something else like Rupali is doing aphasia, really great practice. If I am having any doubts, I can ask Rupali also. Yeah, I am having this doubt. So what do you think? So if we are meeting 2 or 3 months, once in a 2 or 3 months, we are doing workshop. So we should have also great relations. Otherwise, I don't know what he will think, what he is doing, he is doing wrong, he is doing right. But some people might be doing wrong unknowingly because they don't know. But when we will meet, we can correct ourselves also and we can correct themselves also. And we all will have good coordination. And then like if we have main problem of malpractice, okay? So we could think about the other countries, how America is dealing, how European country is dealing, how African country is doing, even Nairobi is doing well. So how Australia is doing. So in America, if I say ASA and AAA, they have two organizations. Many private practitioners are associated with AAA. They are associated with ASA like ISA, but they have different organization also, and they are dealing their own problems, own agenda over there. And they can collaborate like ASA and AAA is collaborated foundation. So nobody can do any kind of illegal things over there. Then now Rampo has started ISA Connect and Collaborate. So we are now meeting like this, and even we can think about the one more strong organization, or we can ask ISA to do something extra mile for to stop our malprofession. Okay. Thank you.